10% improvement in the peak. And this was useful to us and others in terms of understanding this idea of flattening the curve. Next. As I said, dynamical models are what we use as a bridge. Right now, people are talking about opening and what's going to happen when we open. Dynamical models are the tools we use to predict what's going to happen when we open. And they're also the tools that we use to try to get the parameters for those predictions. So this is work we did with Daniel Park from Korea, where we look at the apparent response of transmission in Korea to social distancing. And so we're taking the bridge from Korea back to what it seems like the effect of what people were doing were, and now we want to try to take the bridge in the other direction and ask, can we project this and learn about what might happen as we reopen? I'll mention also that interpreting these is exactly the questions we've been asking about generation intervals and serial intervals. I don't have time to get into those details next. Dynamical models are good for proof of concept. So people have been talking for a long time about finding out who's immune and using them as a way to bridge between people who might be susceptible, right? So if we find out that people are immune, maybe those are the first people who go back to work in the long-term care facility, for example. And we published a paper recently as a proof of concept showing, yes, that if we make certain reasonable assumptions about how that works, how much do we expect it to reduce the size of the epidemic? Next slide. And we're also working on what happens as a population, either individually or in terms of policy, responds to an epidemic. So simple models I've shown you have a big upward slope and an almost as quick, in many cases, downward slope. But if people are responding, if they social distance when they see the epidemic is bad and then start to relax when it seems like time to relax, we can get very different dynamics. Next slide.
Jonathan, it's Mary, and this is your 1-minute reminder you requested.
Thank you so much. I will be done in 1 minute. So the dynamics we get from this simple model seem to match fairly well the kind of things we see in much of the world, including you see that China now may be on its way up. Of course, that may be a different province. But next slide. Depending on how we model behavioral or policy reactions, and depending on whether we assume people's memories are long or short, we see that we might expect long shoulders instead of a sharp decline or even this kind of oscillation. Next slide. So going forward, I'm working on the things I told you about. Next slide, and thank you very much for your attention. Sheena, I'd like to introduce Sheena.
Hi, everyone. I am just going to switch over the slides. My name is Sheena. I was a Master of Science in Global Health student a couple of years ago, and I did my thesis with Dr. Andrea Bowman and Dr. Dushoff on looking at a qualitative perspective on the infectious disease modeling that Dr. Dushoff just talked about. And when I was a student, Zika virus and Ebola were the two outbreaks that were really in the news all the time. And I would see headlines like Ebola cases could reach 1.4 million within 4 months, CDC estimates. Now, with the presentation that we just saw, we kind of understand that that number is a very simplistic number to report, considering what really goes into building a model and the statistical considerations. And so communicating it like that is quite simplistic and maybe inaccurate. And when I was a student, my interest was piqued into who is creating these models and who is using them, which is why I went down this rabbit hole of trying to figure out who were the key stakeholders and what was being said qualitatively around the mathematical models. So one of the things that I did was a qualitative study where I interviewed the 4 key stakeholder groups that are involved in this field. So academic modelers, similar to what Dr. Dushoff does, government end users, these are the people that are using the results, like policymakers of the mathematical modelers, practitioners and professional end users, a group that consists of journalists who are doing the reporting, or public health physicians that are working in hospitals trying to understand how their next week, next month will look, and government research modelers, mathematicians that are situated in the federal government. Those are the 4 groups that I had interviewed for my study, and what I was trying to map out is what issues are these stakeholder groups interested in, and how do these issues interact between the stakeholder groups. So for example, I have a stakeholder issue interrelationship diagram, a very simplistic, watered down version of what the issues are. So you see around the slide, the education data surveillance systems, and how the 4 stakeholder groups interact with them. So education, for example, you see that all key stakeholder groups are interested in education. This includes post-secondary education, students in undergrad who are maybe in a mathematical program to kind of bridge their understanding between public health and the models that they're developing, as well as continuing professional education programs, so people who are out in the field doing public health work, for them to get the most up-to-date education and what the research is saying. Another issue that these stakeholders had identified was knowledge translation risk communication. The end users, a journalist, for example, who was communicating these complicated results from academic publications, really needed to have a skill set where they communicated this well out to the public. And the government end users who were using these results also needed that knowledge translation piece to be in place so they could understand the results that were coming out from academia or from modelers, and then practically apply it to a setting. I also did a bit of a thematic analysis, and I've just pulled out some of the themes that I thought were relevant. So the perceptions of modeling results from these key stakeholder groups, they really appreciated it because it helped them to understand an outbreak, and it did that by providing these uncertainties, these ranges, these confidence intervals that they could apply in various scenarios and prepare for the pandemic. Another theme that came up was public action, and I have a quote here from one of the end users that said, he was talking about they were talking about the Ebola modeling results that had come out, and said, yeah, I mean, now we know they're way off. Now, I'm not saying that was really problematic, to be honest, because it got people's attention. So the models were being used to understand, but also kind of get that attention, which really augmented that public health response. Another cluster of themes that came out from my research was the theme around data and the challenges around it. So you see the challenge of data collection. We had an academic modeler in the study who quoted that if you only have 5 variables in your data set that you can look at, that's all you can use, but maybe those are not the best 5 variables. And something that I heard again and again is that the quality of the data that you input in is really the quality that you're going to get out. So garbage in, garbage out. Other things that came up were the dependability and trustworthiness of data sources and the challenges in accessing global data, which I'm sure this group is really understands and can understand the nuances of each country having their own public health systems, some being more prone to having better reporting systems than others, and how that can create this challenge in getting a good global picture of what's happening with an outbreak like we're seeing with COVID-19 now. And so for COVID, we still see these headlines of headlines that are saying these projection numbers, but without really any context, without really any nuance on it. So I think it's just important when you're looking at mathematical modeling to really understand who is creating the models, what data was used to build the models, who is using them, and in what capacity, and how are these results really being communicated. And that's it for me. Thanks.
Thank you very much, Sheena and Jonathan. That was a really two expansive presentations. I wanted to get our questions started with something about the types of modeling and what your recommendations might be now, where COVID-19 sits right now. Are there models that you would recommend be used so that we can understand where COVID-19 will go next? Can you help us with that one? What models would you use?
Well, we are using models. At some point, how to put it, we're thinking now about opening up. And I think the most important aspect to opening up and what we learned from sort of a broader dynamical picture is that we want to do it gradually. and we want to pay attention to how it's working and whether it's working the way we think. So you need a dynamical model to do that. You need something that can look at data and translate them into a measure of infections per infection and how that's changing through time. I think which model you use, and we are trying hard to tune these models, which model you use right now is less important than the idea that you're moving gradually, paying attention, and doing a quantitative analysis of the data, ideally with dynamics in mind. In terms of the technicalities of the model, I don't know that I could get into it, and if I could get myself into it, I don't know that I could be understood in a reasonable amount of time.
Okay, great. So the idea that it's a dynamical model and the idea that you're saying, let's do this opening up fairly gradually. When we use the term gradually, of course, being a qualitative type term, there's different interpretations, and right across our own country, as an example, gradually has been interpreted in many different ways. Is it from your perspective that we would err on the side of caution, or are you proposing that we should be as slow as possible, understanding what the implications are for our economy, or do you have a sense of what does gradually mean to you, understanding how different jurisdictions are doing this?
So from a pure, that's a hard question, and I may wind up begging off. From a purely dynamical approach, I think there's, in a lot of jurisdictions, I'm not super concerned with how gradually things reopen, because I think there will be time, as long as we're paying attention, I think there will be time to recorrect if recorrections are necessary. The other part of that is that I think things are going to be gradual from the point of view of the population, no matter what the government says. We're not all going to go back to handshaking and hugging the way we did in December anytime soon. The reason I said I might beg off is that the really hard problem is how bad is it to go too slow versus how bad is it to open and then have to pull back, right? And that's really not something that's in my expertise. If I had a control machine, if I were confident that it was okay to pull back if I needed to, I would not have big concerns about being gradual in many jurisdictions at this time. But that's really the hard questions now. We definitely need to pay attention. We definitely need to take the health risks seriously. But the hard questions now are balancing the health risks against economic and social problems. The economic and social problems of staying closed, and the economic and social problems of yo-yoing, meaning of opening, closing, opening, closing.
So from what I'm gathering, your preference would be to not have to go through the yo-yo.
I'm saying I'm not an expert on that. I don't know if Sheena wants to pipe in.
Sheena, any hunches there?
No, not my area of expertise either, so I don't want to say something that could be misleading.
Okay, great. Thank you. Let's move to the next question then. How much uncertainty is created by not knowing the true number of infections due to asymptomatic or mild cases that are not discovered? So let me read that one again. How much uncertainty is created by not knowing the true number of infections due to asymptomatic or mild cases that are not discovered? Who would take that one on?
I would like to take it on, even though I've talked too much already, unless you want to go first. Okay. So that's the big one. The answer is a lot of uncertainty. We really still don't have a tight bound on how many people have been infected, and in different ways than you might expect. So obviously, if there's more infections than we think, then the disease has spread more, and that may say something about control. If there's more infections than we think, then there might be more immunity already in the population than we think. And given that we also don't really know everything we need to know about social networks, that could turn out to be an important component of control. We really want to know going forward, as we see these estimates of big R go down, how much of that has to do with the effective immunity of the network versus how much that has to do with policies and changed behavior. And the third reason is that it's very tightly tied to the intrinsic dangerousness of the disease. If we were to find out tomorrow that Ontario has had twice as many infections as we thought, one of the main things that means is that per infection, we've only had half as many hospitalizations, half as many deaths as we thought, right? Because we have a fairly good idea how many people have died. If that turns out the denominator of that is a bigger fraction of the population than we think, then that's also a big effect. So yes, getting more serological testing, meaning testing of antibodies to see who we think has had the disease, and learning more about how reliable these tests are and getting more reliable tests. This is a huge question.
Okay. Sheena, anything to add there?
Sorry, I was on mute. No, Dr. Dushoff is really the expert in this, so I will leave it to him to
Okay. All right. Next question is about models. And the question is, are there models being used to predict the second wave that we're now hearing about? So, are there models being used to predict the second wave that we're now hearing about?
So the short answer is yes. I showed you a model that can generate one possible mechanism for second waves. There's so much uncertainty about the first wave, even whether it's completely on the way out. There's different definitions of what you think of as a first wave and second wave. Is a second wave, once we've started to go down, if we go back up, does that already count as a second wave? And that's something, for example, that's already happened in Quebec. Or are we talking about if the disease really gets beat down? Dynamical models do suggest a variety of different mechanisms for a second wave, mostly having to do with opening up or with relaxation in people's worry about the disease, or new births, right? People who are moving into the newly susceptible class, or children who are moving into school, or possibly even the weather, right? So what's unknown now is the long-term interaction between COVID-19 and seasons. When influenza is new, it doesn't care much about seasons because everybody's susceptible to it and it burns through the population. Once it approaches a balance, like you saw my blue and red curves that sort of approach a balance and wave around, then we might start seeing how the new coronavirus is interacting with the seasons.
Okay, thank you for that. In terms of moving into that discussion about modeling, you mentioned that dynamical models were more useful, as I understood what you said, were more useful to you than perhaps phenomenological models. Are there people that are using a combination of both, or are people usually in one camp or the other? Or can you talk a little bit about what you and your colleagues find most useful going forward in terms of the types of models, whether the kinds that you had discussed already, or where things move in the future? Are there trends happening in your world that around modeling that you can tell us more about?
Okay, that question sort of took a turn. Sheena, did you have thoughts about types of modeling?
I think, Sheena, you're still on mute there.
Yeah. No, I don't.
Okay, I'm just going to, okay, I don't want to be stepping on you, and I don't want to be putting you on the spot either. So in terms of phenomenological versus dynamical, I'm a dynamical modeler, but I do see the value in phenomenological models, and I think a lot of us do. I think as a pragmatist, I want to be able to use the tools that work. And I'll mention that Theresa Tam and the Public Health Agency of Canada have talked very clearly about when and why they use phenomenological models for short-term forecasts and dynamical models for longer-term forecasts. The world is a dynamical system, and the more we can learn, the more we're able to be mechanistic and put reality into our models. And we learn so much by doing that, both in terms of counterfactuals. Well, what might have happened if we had done that? In terms of planning, what might happen if we do this? And in terms of understanding mechanism, right? So that dynamical models are what allowed us to infer with some confidence that schools were a really important forum for transmitting measles, because measles showed these regular patterns for decades before the vaccine was introduced, and people were able to fit very detailed dynamical models to them. So phenomenological models are useful when you don't understand enough, and in particular when you have information that you want to use but don't understand mechanistically, right? So if we see a pattern that's happening over and over again, but we don't understand it well enough to put into a dynamical model, we would certainly want to consider using a phenomenological model that says, you know, the rotavirus outbreak in North Carolina might look like the rotavirus outbreak in Alberta, because we know that rotavirus outbreaks have commonalities that we don't understand.
Okay, thank you for that. Technical question for you, just stretch another part of your brain here, Jonathan. I hope you're ready for this.
Always.
The capital R that one reads in the news, is that referred to as the expected value of capital R in a stochastic model, or has that necessarily been calculated from a deterministic model? So let me read that again for our audience members. The capital R that one reads in the news, is that referred to as the expected value of capital R in a stochastic model, or has that necessarily been calculated from a deterministic model?
So the answer is you can do it either way, or you can even do it agnostically. So the way people estimate capital R is they look at some proxy for disease, and they look at some measure or estimate of the time delays, and they try to figure out what value or values of capital R changing through time are likely to predict what's seen. But it's absolutely consistent with an explicitly deterministic model, which would then model all the noise that you see as observation noise. Would assume that the disease is spreading like a perfect machine, but we're somehow not seeing it clearly. It's absolutely possible to do that with an explicitly deterministic model, and it's possible to do that with a purely statistical model that makes sense and deals with the delays but doesn't necessarily care.
Okay, thank you for that. Has there been any work done on the types of behaviors put into place to help manage this coronavirus? So as an example, are you doing any work in the area of what's testing doing, what's tracing contacts doing, what's isolation doing? Are there any models that you're using to take a look at those interventions and where they're most appropriate to be put into place?
Yes, so there are both inferential models that try to figure out what's working and what isn't now. And there are also predictive models that try to figure out either by using the inferences and try to actually figure out what's going to work, or just by making simple assumptions. If we assume we can trace up to this many people or up to this proportion, how well would it work? So all of that is going on. And that's really, the inferential part is really an exciting time about now. We're sort of racing to try to see what we can about how well we think various interventions have worked. And we're also very much getting ready to look at places opening up and see if we can see how things change and see what happens when we compare. So this morning, I didn't have time to follow it up, but this morning a lot of people are talking about comparing Sweden with Norway, because Sweden took a fairly open approach. They said, you know, we're going to keep doing things as normal, but we ask people to be aware of the fact that coronavirus is a real thing and practice distancing and not do extra. And so it's very interesting to see how did that approach compare to that of other countries, in particular similar countries. And I think the news this morning is that things have been a little rougher in Sweden than people thought. But we're doing exactly that.
Okay, great. Thank you for that. A question now about immunity. So a little change of topic. How much do we know about the effectiveness of immunity to the COVID-19 virus?
So specifically, I think almost nothing. And I'm really very much not an expert. This is one of the areas where I'm not an expert, but I'm fairly opinionated. So I sort of want to say things, but I don't necessarily want people to believe me.
Okay.
So for most of the viruses that I studied when I was younger, things like measles, chickenpox, rubella, your body mounts a response, and the last part of that response involves antibody and T cells that have memories, and you may get assaulted by that thing again, and you may even have to mount a noticeable immune response again, but you're never going to get sick again. And that's my paradigm, but it's not always true. Biology is infinitely complicated. And some of you may have noticed I mentioned chickenpox. You never get chickenpox again, but you can get shingles again, which comes from the same virus. So there's exceptions to everything. It looks like people are beating coronavirus roughly in the standard way, meaning that people who beat it probably have immune memory to it. And if they're challenged again, will probably, on average, do much better than they did the first time. How much better, we don't know. Might they get a milder version of the illness? We don't know. How good are people who are reinfected going to be at spreading it compared to people who were infected the first time? We don't know. What's the time scale at which this gets worse and worse? For measles, for example, even 40 years later, you can respond very effectively to measles. For COVID-19, we don't know that either. I don't think that immune loss is going to be very important in terms of the first wave, but who knows after that? Some viruses, some diseases, you can get sick again after a few years. So the answer is there's a lot left to know, but there's reason to believe that that level of immunity is going to be important. That people who've had it are going to be, at least for a while, much less sick on average and much less able to transmit on average than people who haven't had it. And I say reason to believe carefully. We're not sure and we need to keep paying attention, but it's fairly likely that that's true, and we may want to go ahead sort of assuming that with our left hand and questioning the assumption with our right hand.
Okay, great. Thank you so much for that. Just by way of clarification, how do you distinguish between immune memory and immunity?
So that's an interesting question. When we say immunity, when we say we have immunity to the disease, we're usually talking about the adaptive immune response, which is also what we call immune memory. Your overall immune response is much broader than that. And there are some things you're doing with inflammation and white cells to fight the virus, which don't get reflected in immune memory, and therefore aren't usually what we would call immunity, but they are part of what we call the immune response. And so when I'm talking about people beating the virus with their immune response, not all of that comes into what we call immune memory or immunity. Some of that's just going to fade.
Okay, great. Thank you. And a final question for both you and Sheena. You're both very enthusiastic about your areas of study, and that comes across clearly. What excites you most about what's next in this area of study?
Now's not the time. We're just scrambling to keep up with this COVID craziness. I would say that before and after, what excited me the most is sort of if we can get a solid theoretical understanding of these time distributions, things like incubation time and generation interval and serial interval. And I guess what I'm excited about is building an understanding of these things that's going to make us able to respond more effectively to the next outbreak. And I feel like we're kind of doing that, although it's hard to lift my head up above the water for long enough to be sure right now.
Okay, thank you. And Sheena, how about you? What excites you most about the future?
Yeah, why I originally became interested in the project that I worked on with Dr. Dushoff is that application of the modeling results and how we can apply it to public health. I think we're going to have outbreaks in the future, so to have people that can take these results that Dr. Dushoff is developing and then bridge that gap between the modeling and the policy and the public health and the best ways to do it is something that really excites me and what I hope to work on in the future.
So both of you looking at application of what you're up to. Thank you so much for responding to those questions. And I want to thank all of our audience members for those fascinating questions. And we hope that this exchange was pertinent to your expanding understanding of pandemics. But most importantly, a special thanks to our speakers, Dr. Dushoff and Sheena, for your excellent presentations and the insights you've provided so enthusiastically in the Q&A with our global audience today. We really appreciate your distinctive contributions to this webinar series. So let's quickly wrap up. I want to thank everyone for attending today's session. We look forward to hosting the 8th webinar entitled Perceptions of Past Pandemics, Cultural Histories of Public Reaction to Disease Outbreaks. That's certainly something really prominent in the media these days. This will be held on Monday from 12 noon to 1 p.m. It features Dr. Sonia Delat, McMaster University. And in this webinar, you'll learn more about applying historical thinking to perceptions of past pandemics. So if you haven't registered for webinar 8 or the final webinars in our series, you can do that through the link on the website globalhealthmcmaster.ca/2020 webinar series. So enjoy the rest of your day, everyone. We look forward to your participation in our next exciting webinar. Thank you. Merci. Gracias. And danke.